All right, thank you so much, Dr. Prince, Michael, Ramon, for really getting this convening off the ground. It's been inspirational to see over the last 4 or 5 years how this movement has grown and the number of health systems that have really joined this cause. So very excited to have this conversation. We're gonna try to get really granular today with a conversation about data, because this is one of the few elements when we talk about gun violence prevention that has bipartisan support and is critical in moving the needle forward with an approach to firearm injury prevention. We can't evaluate many of our interventions. We can't understand this epidemic without comprehensive, real-time data. And we have an amazing panel here to kind of share their insights. So I'm gonna start off with some introductions. I'm gonna have, we're gonna start with you. Please tell us a little bit about your background, what brings you to this, what you're working on as a starting point.
Okay, thank you, Chetan. Good morning, everyone. I'm Abdul Sheikh. I'm the global leader for population health for Amazon Web Services, which is the cloud computing arm of Amazon. I've been with Amazon for 3 years, and I have an amazing team. Our team's goal is to help our customers, our partners, really harness data. Data for health equity, data for the quintuple aim in healthcare, data for driving prevention of gun violence. And so for me personally, this is an important issue. I trained as a public health educator. I was at NIH and ONC, where I also was involved in driving research around care quality and impacts and using technology as an enabler. And now I'm at AWS, and so I'm really pleased to be here to be able to both share what we're doing, but also to learn from you all.
Thank you. Stephen?
Hello, everyone. Thanks for having me. My name is Stephen Sumner. I'm a physician, and I serve as Senior Advisor in the Division of Violence Prevention at CDC. The focus of this panel and this day is data, and in particular, data from the healthcare sector. I think there's really tremendous untapped potential to help communities here make better decisions about prevention, where to allocate resources, and then to be able to measure the beneficial impact of those things over time. CDC has been working a lot lately on taking advantage of new data sources, particularly data from electronic health records that I think offer tremendous potential in terms of being able to have a much more timely and local understanding of firearm injuries across the country. And ultimately, our interest at CDC is not data for data's sake, but the ability to use data to really drive prevention at the local level. So thank you for having me.
Thank you. Mark?
Well, first of all, thank you to Northwell and to Michael for inviting me to this. I'm Mark Bryant. I'm the co-founder of the Gun Violence Archive. We started back in 2013 because we were seeing a very large gap in data. FBI was not particularly forthcoming and was for 18 months late. My friends over here at the CDC also very late in getting data, but it's because they have such a large job to do. We needed something that was close to real time. We designed a system that gave us that opportunity. So now when we're looking at data, we don't have to look at data that's a year old or a year and a half old. We can start looking at things that are, as an example, when we were having, there was a meeting last night. While we were there, a man got shot in the head and killed at a bodega a couple of miles down from here. And on the other end of the country, in the northwest area of Alaska, a family of 4 was shot and killed. So this goes on daily, and we're here to help get a picture of what that data looks like everywhere as fast as possible.
Thank you, Mark.
Thank you.
Thank you. And when we talk about data, right, it's a complex ecosystem, because gun violence, as we all know, means firearm suicide, public mass shootings, community violence, unintentional injuries, and they're also different in their root causes, risk factors, and the ecosystem of data that's required to really track that. That nuance is incredibly important. I think before, I do want to dive into barriers, because I think it's important to talk about the barriers and why we haven't been able to overcome them and what we have been able to do. But Mark, just to get a little bit more detail from each of you, and we'll start with you, Mark, you've had an incredible journey building the gun violence archive. I think many people in the crowd understand that most of the stats that we cite in publications, New York Times and so on, a lot of them do actually, many years ago, did come from the gun violence archive and continue to in a real-time fashion. Can you just talk about how you actually collect that data right now, just to give the crowd a sense?
We started out very naively with 4 people, assuming that we could cut the country into quarters and start getting the data. And by the 3rd day, we were behind. So over a few days, much to the concern of our angels that were funding us, we've moved up to 24 people. I've got mainly librarians, master's librarians. I've got a couple of PhD, and then I have my friend from that I've known for a long time. That she's 70 years old. She does Chicago. She has a GED. And if something happens to her, I'm in deep sneakers. It's going to get bad very, very fast. So we built this up from data managers and data architects out of, I stole them from IBM. And as I left, and that gave us an opportunity to have good talent doing the work. And so now we have a system that is very, very good, and we have been building it over the last 3 years to accommodate this shift to healthcare, because we've seen it coming for the last 3 to 4 years. And so we've started building a foundation that's going to be better for providing the data, for inputting the data, and for letting all of you have free peeks at the data whenever you need it.
And Mark, sir, on a daily basis, how are you getting the bulk of that data?
We have 10 different ways. I have the 24 people that are physically eyeballing newspapers and police reports and police blotters. Social media has built up a lot. And then we will start seeing things that way. We are also starting to look at AI to get some stuff, but I'm not comfortable with that right now, even remotely. We're also looking at we've got a lot of, we use Google and Bing and others to do searches. And we have a lot of searches that go on generally every day. So we're able to pick about 98% of what happens that gets reported. The key is that gets reported, because a lot of things in the healthcare industry never make it to police blotters except in aggregate. They never make it anywhere except in aggregate, and then we lose that granularity that we want.
Yeah. No, and that's such an important point for people to understand. I mean, you're literally scouring the internet.
Yes.
To get us this data, just to paint a picture of how much work we have to do. Stephen, in 2 minutes, can you summarize all of CDC's work in the data space?
I like the introduction you led with, because understanding firearm injury really requires looking at things comprehensively. As many in the room know, cities often use law enforcement data and other publicly available data sources because of the timeliness, but there are key gaps in those data sources. For example, those data sources generally don't contain information about suicide. And what many people are unaware is that firearm injuries from suicide and suicide attempts account for more deaths in the United States than firearm homicide. And so it's an important picture, particularly for rural communities across the US, to be able to have access to data and information about the burden in their community. So CDC collects data on both fatal and non-fatal injuries from firearm suicide across a variety of what we call intents. Assault and homicide, suicide and self-harm, and unintentional or accidental injury. Our large data system on fatal injury is the National Violent Death Reporting System. It contains detailed information on the circumstances of each death and has been tremendously useful. We're seeing increased utilization every single year by researchers across the country. And then increasingly, and relevant to this meeting here today, is we are really increasing our use of real-time data from electronic health record-based sources. CDC operates what I believe is the largest real-time system from about 75% of participating emergency departments across the country, and that gives a near real-time picture of what's happening nationally in terms of firearm injury. And we are increasingly funding state and local jurisdictions to be able to do that same work at the local level, produce dashboards for their local community, and really make the information relevant there.
Thank you, Stephen. Great job. 2 minutes. That was quite comprehensive. So we'll flip it over to you, right? Talk a little bit about what Amazon's doing in this space.
Okay. You know, it's not easy for me, being a Michigan grad, to talk about Ohio, but you know, Amy, I want to riff on what you shared, which is there are some incredible things happening in the state of Ohio. We at Amazon are very proud to be supporting the Center for Health Affairs in Cleveland, and we helped them establish a social determinants of health analytics hub. But what they're doing there, because this is a nonprofit hospital association, I think the second oldest in the country, and they have Cleveland Clinic, Metro Health, other amazing partners, including partners in the community and the local government. And they're focusing on gun violence prevention and behavioral health as a start. And so I think when we think about data and the need to understand data and how to link data, what I really appreciate is how the Hub and the Center for Health Affairs, they're bringing in data from the clinical record, right? Using FHIR, FHIR data models, but trying to combine that with data from the public health department, from local law enforcement, from other nonprofit agencies, and then public data, right? From CDC and other resources. I think that's where it really gets exciting, right? Because we want to be able to understand individuals, families, and communities within their context when it comes to gun violence, right? And what are those drivers of gun violence for prevention, those root causes? They don't happen in a snapshot, right? They happen over life course, they happen over a period of time. And so I'll pause there. I could keep talking about what they're doing. I might bring them up again, but I think that's a great example, and I'm happy to talk about it afterwards in the breakouts as well.
Thank you. No, I think that was incredibly well said, and again speaks to this ecosystem of data that's required, private, public partnerships, cross-sector collaboration. So Stephen, in your mind for the CDC, where would you like to see things go with respect to data? And specifically cross-sector collaboration, what would be your ultimate vision and how do we get there?
Mm-hmm. Yeah, well, I've mentioned fatal data and non-fatal data, and really the desire to continue to make those more timely and local. I think that's tremendously important in terms of having communities be able to understand where resources are most needed and then measure impacts of prevention programs over time. I think when you talk about data, though, it's important to think comprehensively, and other important areas to consider are measurement of the upstream risk and protective factors in communities, things that ultimately influence those health outcomes. So for example, CDC is working to expand information at the state level on secure storage practices related to firearms. We anticipate an increase from about 6 states to 18 states this year participating in our firearm safety module through our large national survey. And where there's also a large gap is data collection efforts around really the reach and extent of prevention programs at the local level. But that's the ideal situation where you have information, really granular information on the health outcomes that are happening at the local level, and then the scale and the scope of the prevention programs that are being implemented, because then you can have a beneficial feedback loop where you really understand whether what is being implemented is having the positive impact that's being sought.
Mm-hmm. And just to kind of delve into one point there, how do you build that trust with the various stakeholders, including folks on the ground doing the hard work, right, in the community, in a way that it works for everyone? I mean, have you seen successful models of that?
I think it's an active area of development. We are seeing several of our grantees increasingly, like I mentioned, produce local dashboards, engage the community in increased ways. One of the programs that's well known internationally that CDC has also been involved with is the Cardiff Model for Violence Prevention. That's a program that began in Wales. CDC was involved in the original evaluation of the effectiveness of that model, published in the British Medical Journal, showed a tremendous impact on violence in Wales. And it essentially puts forth a cross-sector community prevention board that uses combined law enforcement and health data through maps to reflect on particularly where violence is happening in the community, and then to implement place-based solutions to that violence. So there are models, both local and international, that we can consider, and it's an important area to keep building out.
Mm-hmm. Mark, what about you? What are the big barriers that you foresee, and how do we get to the ultimate vision?
Really, cooperation is going to be the key to getting a lot of this done. We find that a lot of the federal agencies, which are wanting to start gluing their data together, but they're very proprietary over it, and their own data, and all the systems are individually designed. So there's got to be somebody's going to be needing to go in and set up a skeleton that lets you hang every bit of data on every one of those, so you can then aggregate it much easier and get better trending. But we're finding even it goes down to a level closer to the ground than that. We're finding that some political issues are coming up where some sheriffs of large counties refuse to send data. A good example of that is in 2013, there were no homicides in Florida, which I want to congratulate Florida for that. But there's something that just keeps bugging me about that data. But cooperation is the thing that we're seeing that is that we think that is going to have to be worked on a little bit harder to get all of this going.
It's well said. It's well said. And we struggle, with the same issue here in New York State.
Yes.
So, from your perspective, Abdul, how can we actually leverage technology, and how are you already leveraging technology to enhance exactly that issue, right? We know that there are workflow issues. We struggle with that as physicians, law enforcement, right? People are busy. So how can we leverage technology to make this easier?
Ooh, great question. I'm going to give you a couple of examples which strike me as appropriate here. When we think about data, and when we think about what it means today when you have approaches to analyze and use data like AI, right? Generative AI. It's a little scary, right? There's unknowns. And I think generative AI in particular is really helping us redefine how we look at privacy of data. And I think when we think about data privacy, generative AI, these other tools, what's important is to think about the data itself, and is it representative of the populations that you're looking at? And is there bias in the data? What is the data provenance, right? Its source. And how can you augment that? What data that's qualitative or quantitative, and still have valid sets of data that you can then analyze and get conclusions from. What I think is promising and exciting is that there are tools, there are approaches to be able to set guardrails around how, for example, large language models and generative AI, the type of data that they actually ingest, and then how those large language models are used within an organization. So you're actually protecting the privacy, for example, of patients within Northwell Health versus subsets of that data that are then redacted and shared in a larger model. So I don't want to get too technical, but that's one thing I think it's promising, right? That there's tools, there's approaches to set guardrails around the use of these analytics. The second thing I think is, we're all passionate about making data actionable, right? What's the use of that data? And I think for me, I look again to, an example would be the Center for Health Affairs. I was on a panel with them recently, and they had Cleveland Peacemakers, one of their community partners, on the panel with me. And they talked about how for them it's so important to be involved in this analytics hub so that they can get data to be able to use it at their point of care when they're sending a team member to a family who has been impacted by gun violence. How can they make that data useful and actionable for them? Right? What would be the value for them? And that's an important question, I think, to ask. And that's what I think we're all probably asking as we work with community partners, with payers, with providers, and others. So I think those two things strike me as areas where it would be great to talk about in our breakouts.
Mm-hmm. Well said. In 10 seconds, just quickly tell me, because we have a minute and a half, and I want to end with an important question. What is, for a corporation like Amazon, right? What is the ROI argument to actually delve into this space?
Okay, we believe in doing good. We have a customer obsession, right? Amazon, that's our number one leadership principle. But we also have a leadership principle that we have a responsibility to society. And so through that, we've been involved in launching a number of initiatives. One I'm really proud of, and I'm involved in, is the Health Equity Initiative. It's a 3-year, $40 million grant for cloud credits. And to date, we're now getting into the third year. We've awarded $32 million of grants to be able to drive initiatives on using data and analytics for outcomes around health equity. One example is we have an amazing researcher in a health system who's using those grants to look at the ability to model and predict suicide prevention by combining data from the clinical health record with data from credit bureaus. And so that's just one example of the initiatives coming out of that. And that's a live program right now. So,
well said, well said. All right, so we'll end on an optimistic note. And I also want to have a little bit of a controversial question. Mark, we'll start with you. So what gives you optimism? And number two, how do we also address the elephant in the room at times where data is increasingly becoming something that people want to own, right? And there is a tremendous competitive atmosphere around data. And I think that has stemmed and resulted in a lot of issues with data sharing. So I would pose those two questions to you.
To the question of ownership, we started 10 years ago with the idea that we would share everything for free. And we've worked with that system for a decade. And it has worked very, very well. We did find at the beginning some people were scraping our data and using it commercially. That angered our funders a little bit, but otherwise, we think that just giving the data away is the only way to make it work, because everybody needs to have a common set. As we say in the South, everybody needs to be singing on the same page of the hymnal. And if you're not, then you start having problems.
Well said. Stephen?
Well, when it comes to official health data ownership really occurs at the local level. And so CDC is subject to the laws and the policies that are set at local level around things like data suppression criteria, data sharing. And so it just further emphasizes the need of really cross-sectoral efforts and having a long vision in terms of data. But if you look over the past decade at the progress that's been made related to data, related to violence and firearm injuries, it's really tremendous. So I'm incredibly optimistic about the future.
Well said. And we'll end off. Abdul.
Thank you. As a public health professional, I'm really just heartened by how we have such cross-sector involvement. We need to have the community at the table. We need to have their voice at the table, especially those voices that are underrepresented. And that's what really, I think, heartens me about even the room here. As a scientist, I'm excited. I'm excited by our ability to leverage the cloud and analytics and AI and natural language processing and all these tools and toys. There's real potential there, and we need to figure out the guardrails around that. And then as a parent, as a father, as a brother, as a son, as a community member, I also feel optimistic. And I think I want to riff back on Michael, how you opened the meeting. that really was inspiring. And I think that's why I'm here, and I think that's why you're all here today as well. That's great.
Thank you. Thank you so much.
Thank you, Mark, Abdul, Steve.